Hi, everybody, and welcome to our module on renal endocrinology. The kidneys are not usually considered part of the endocrine system, but there are a number of hormone or hormone-like substances that are either released by the kidneys or that act on the kidneys, and so we'll go through all of the items listed on this slide in this video now. I'm going to start by talking about the enzyme renin, which is released by the kidneys, and in order to understand renin, we have to first talk about the JG apparatus, which stands for the juxtaglomerular apparatus. This structure gets its name because it's found near the glomerulus, and within the JG apparatus section of the kidneys, you can find JG cells. These are modified smooth muscle cells of the afferent arteriole, and these are the cells that synthesize and secrete renin. Also within the JG apparatus, you can find the macula densa. This is part of the distal convoluted tubule, and as we'll see in a minute, the macula densa is important for triggering the release of renin. Here's a drawing of the glomerulus. This is the afferent arteriole where blood comes in. This is the efferent arteriole where blood exits the glomerulus. We've got a distal tubule shown right here, and this area in between these structures is called the JG apparatus. This is where you can find JG cells. These are modified cells of the afferent arteriole. This is also where you can find the macula densa. It's shown in green in this drawing. It's a portion of the distal tubule. Shown on this slide is my own diagram of the renin-angiotensin-aldosterone system, or the RAS. This is a system in the body that is activated by renin, and its job is to increase salt and water retention and raise the blood pressure. It is a response system in response to low blood pressure or low circulating volume. The way the system works is that JG cells release renin, which then converts angiotensinogen into angiotensin 1. Angiotensinogen is a substance constitutively produced by the liver. It can be found in the plasma, and when it encounters renin, it is converted into angiotensin 1. In the lungs, there is an enzyme called angiotensin converting enzyme, or ACE, which can convert angiotensin 1 to angiotensin 2. And then angiotensin 2 is the workhorse of the RAS. It has a number of effects, all of which are shown on this slide. The key effects are bolded in red. These include renal resorption of sodium and chloride, vasoconstriction of arterioles, and also triggering of the adrenal glands to release aldosterone. In addition, angiotensin 2 can activate the sympathetic nervous system and trigger the pituitary gland to release ADH. And all of these effects together work to raise the amount of sodium and water in the body and to raise the blood pressure, and therefore this system is a response mechanism when blood pressure or vascular volume gets low. There are three stimuli for renin release, and they're all shown on this slide, so let's go through them one at a time. The first one is low perfusion pressure. Anytime there is low blood pressure or low circulating volume, this is sensed by the afferent arteriole, and that triggers JG cells to release renin, and renin in turn activates the renin-angiotensin-aldosterone system to raise the blood pressure. So this is part of how the kidneys play a role in maintaining a normal blood pressure. Anytime there is a fall in the GFR, there will be less sodium chloride delivered to the macula densa, and therefore the macula densa uses low sodium chloride delivery as a sign that there has been a fall in GFR, and it in turn triggers JG cells to release renin. Now, just an aside, in the first renal physiology video, I talked about how low sodium chloride delivery to the macula densa can lead to modification of tone in the afferent arteriole. This is part of tubuloglomerular feedback, so this is a second role of the macula densa when it senses low sodium chloride delivery in addition to releasing renin. And then finally, the sympathetic nervous system can trigger renin release by activating beta receptors found in the kidney. In addition to this function, the sympathetic nervous system can constrict through alpha receptors the afferent and efferent arterioles. This will decrease the GFR in times of fight or flight to limit sodium and water excretion in order to maintain circulating volume in the body. Shown on this slide are the key elements of the RAS. The first one is renin. This is the substance that gets the whole system going. Its job is to convert angiotensinogen to angiotensin 1. Second element is angiotensin 2, which has multiple effects. We'll go through all of these in this video today. And the final substance is aldosterone, which we'll also talk about later. It has effects in the collecting duct of the nephron. It can trigger the resorption of sodium and also the excretion of potassium and hydrogen ions. Next, I'm going to talk about angiotensin 2, and before I get into the specific effects of A2 on the kidneys, it's helpful to understand the big picture. So let's imagine that we have a kidney, and the job of the kidney is to excrete sodium and water into the urine. In the setting of low blood pressure and low volume, we want to excrete less sodium and water, and A2 is going to achieve this effect through two mechanisms. First of all, A2 is going to decrease the blood that flows through the kidneys. If we send less blood to the kidneys in general, less will go out in the urine. The second thing that A2 is going to do is cause the kidneys to retain more sodium and water. So it's going to say whatever sodium and water does go to the kidneys in the renal blood flow, make sure you reabsorb more of it. Both of these effects, less renal blood flow and more reabsorption of sodium and water, are achieved by angiotensin II. The major way by which angiotensin II achieves these effects is through efferent arterial vasoconstriction. This is the main kidney effect of A2 that you want to remember. So let's look at this drawing of a glomerulus on the screen here. We've got the afferent arteriole bringing blood into the glomeruli and the efferent arteriole bringing blood out of the glomeruli. If we vasoconstrict the efferent arteriole, this will increase the resistance to flow through the system, and this will decrease the renal blood flow or renal plasma flow. And that's going to achieve one of those major goals we talked about in the big picture. We're going to decrease the renal plasma flow. There will be less renal blood flow in general. The second effect of this vasoconstriction of the efferent arteriole is that we are going to raise the hydrostatic pressure in the glomerular capillaries. That is going to increase the GFR and cause more sodium and water to be filtered into the nephron of the lumen. Now you might be saying, wait a second, Dr. Ryan, I thought you said we want to excrete less sodium and water in the setting of high levels of angiotensin II and low circulating volume, but you're telling me the GFR is going to go up. Well, it's true that the GFR goes up, but that is going to be balanced by more reabsorption of sodium and water so that on balance we send less fluid out in the urine. So even though angiotensin II increases the GFR, it does not increase the amount of sodium and water that go out in the urine, and that's because coupled with this rise in GFR, angiotensin II promotes more sodium and water reabsorption so that on balance, we send less sodium and water out in the urine. There are several mechanisms by which angiotensin II increases sodium and water reabsorption. The first one is through increased proximal tubule reabsorption via something called the capillary effect, which I'll explain on the next slide. The second is through direct stimulation of sodium hydrogen ion exchangers in the proximal tubule, and I'll also show you that in a few slides. And then finally, angiotensin II stimulates aldosterone release, and one of aldosterone's roles is to promote sodium retention, so this also leads to more salt and water retention. To understand the capillary effect, let's take a look at this drawing on the screen here. This is the afferent arteriole through which blood comes into the glomeruli, and this is the efferent arteriole through which blood leaves the glomeruli. Now, I already told you that angiotensin II constricts the efferent arteriole, and that's how it raises GFR. But that constriction has two other effects that lead to the reabsorption of more sodium and water. When you constrict the efferent arteriole, you drop the hydrostatic pressure beyond that constriction in the peritubular capillaries. This low hydrostatic pressure creates a favorable gradient for the reabsorption of sodium and water in the proximal tubule, and that is called the capillary effect. Another consequence of vasoconstricting the efferent arteriole is that you drive more fluid across the membrane into Bowman's capsule and you leave more concentrated plasma proteins behind. That raises the oncotic pressure out here in the peritubular capillaries. The oncotic pressure goes up. That also favors the drawing out of more sodium and water in the proximal tubule. So I've summarized these points on the slide. The efferent arteriole constriction of angiotensin II lowers hydrostatic pressure in the peritubular capillaries from less blood flow beyond the constriction. It also raises the oncotic pressure because more water is filtered in the glomeruli and more concentrated proteins are present in the peritubular capillaries. And the net result is that the efferent arteriole constriction by A2 leads to more sodium and chloride resorption. So even though you are driving more fluid and more salt and water into the nephron, you are then reabsorbing more of it so that the net effect of angiotensin II is the retention of sodium and water, which is what you want in a low blood pressure or low blood volume state. In the video on nephron physiology, I talk about the sodium hydrogen ion exchanger, which is important for the reabsorption of bicarb. Angiotensin II can increase the activity of these exchangers. That's going to pull more sodium out of the urine in the lumen of the nephrons and transfer it over to the interstitium or blood. And this is a second mechanism by which angiotensin II increases the reabsorption of sodium and water. Now let's talk about aldosterone. This hormone is synthesized and released by the adrenal glands, specifically by the zona glomerulosa cells in the adrenal cortex. It is a steroid hormone, and this is very different from renin and angiotensin, which are proteins. Aldosterone is a steroid, and therefore it can freely cross the cell membranes, and when it does so, it binds to a receptor that's found in the cytosol. Once it's bound to its receptor, it then modifies gene expression to exert its effects. This is a slide from the nephron physiology video showing the principal cells and intercalated cells of the collecting duct, and this is where aldosterone exerts its effect. It can increase the activity and the number of the sodium-potassium ATPases. It can increase the number of these sodium channels right here, which are called ENaC channels, and it can also increase the activity of the hydrogen pumps in the intercalated cells. Through all of these effects, there will be more reabsorption of sodium and water, and there will be more excretion of potassium and hydrogen ions. And I've summarized these points here. It increases the sodium potassium ATPase proteins and their activity. It increases the number of ENaC sodium channels. ENaC stands for epithelial sodium channels. These are the sodium channels found on principal cells. Aldosterone also promotes potassium secretion from principal cells and hydrogen ion secretion from intercalated cells. The overall effects are summarized here: more sodium and water resorption, an increase in the effective circulating volume. This is a positive effect in the setting of low blood pressure or low circulating volume, more potassium excretion, and more acid excretion. The major stimuli for release are angiotensin II and high potassium. In addition, ACTH can stimulate some aldosterone release, but this is really a minor effect. These two are the major stimuli for aldosterone release. The RAS is very important to understanding the physiology of shock and heart failure and many other disorders. It's also important because there are lots of drugs which act on the RAS system. I talk about all of these in other videos, but I'll just summarize them here for you. ACE inhibitor drugs block the ACE enzyme, which converts angiotensin I to angiotensin II, and this effect will lower blood pressure because there'll be less activity of A2. Angiotensin receptor blockers, or ARBs, directly block angiotensin II at its receptor, and they also lower the blood pressure. Beta blockers have many effects, but one of them is to block the sympathetic nervous system stimulation of the JG apparatus and therefore block renin release, and this is one of many mechanisms by which beta blockers lower blood pressure. There are a number of drugs that function as aldosterone antagonists. These include spironolactone and eplerenone. By blocking the effects of aldosterone, they will lower the blood pressure. They will also raise the potassium and lower the pH. And then finally, potassium-sparing diuretics are drugs like triamterene and amiloride. These drugs inhibit the sodium channel ENaC, which is the channel that's activated by aldosterone, so they will also block aldosterone effects, but not through antagonizing the hormone, through blocking the activity of this sodium channel. Natriuretic peptides are substances released by the heart that have effects in the kidneys. Atrial natriuretic peptide, or ANP, is released by atrial myocytes, and brain natriuretic peptide, or BNP, is the other natriuretic peptide. It is released by ventricular myocytes. The stimuli for release of these peptides is volume in the heart, which leads to myocyte stretch. And it's believed that these peptide systems evolved to oppose the RAS. They have effects that are opposite of the RAS. And the idea here is that if the RAS is overactive, there'll be more volume in the heart. That will lead to release of these peptides, which should dial down the RAS. So it's easy to remember their effects. They're all opposite of the RAS. These substances relax vascular smooth muscle via cyclic GMP. They function as vasodilators and lower the SVR. This is opposite of what angiotensin II does. They also promote diuresis, which is opposite of what angiotensin II does. A major clinical tie-in of the renal hormones and also the natriuretic peptides occurs among patients who have heart failure. I talk about heart failure in detail in videos in the cardiology section, but by way of review, in heart failure there's a decrease in the cardiac output. And so when the left ventricle doesn't pump enough blood and the cardiac output falls, that leads to a backup of blood in the chambers of the heart. And when you have congested cardiac chambers, that stretches myocytes. And so in patients who have heart failure, the levels of ANP and BNP are going to be increased. And sometimes we even measure the level of BNP in the blood to help make a diagnosis of heart failure. Also, because of the low cardiac output, there's going to be decreased filling of the arterial system. And so the body is going to respond the same way it responds to hemorrhage. Anytime there's underfilling of the arterial system and low blood pressure, the body responds by increasing the activity of the sympathetic nervous system and the RAS. And so both the SNS and RAS are activated and increased in patients with heart failure. And it's super high yield to know these first 2 points that I've listed on this slide for your boards. You should also know that even though I told you that natriuretic peptides oppose the RAS effects dominate in heart failure. So patients with heart failure, despite having high levels of ANP and BNP, will have increased sodium and water retention, and they'll have increased systemic vascular resistance. And that's because when the ANP and BNP levels are high, but the RAS is also high in heart failure, the RAS effects dominate the clinical picture. Parathyroid hormone is released by the parathyroid gland, and I talk about this in more detail in the parathyroid video in the endocrine section. The role of this hormone is to maintain calcium levels. It's released by chief cells of the parathyroid gland, and the main stimulus for release of parathyroid hormone is hypocalcemia. Its net effects are to raise the calcium level in the plasma, to decrease the phosphate level in the plasma, and to raise the amount of phosphate going out in the urine. In the kidneys, parathyroid hormone has three effects. First of all, it will increase calcium resorption in the distal convoluted tubule. I'll show you a picture of this in a minute. It will also decrease the reabsorption of phosphate in the proximal tubule. This will lead to more phosphate elimination in the urine. And then finally, it will turn vitamin D into its active form, 1,25-hydroxyl vitamin D, in the kidneys. Now, parathyroid hormone also has effects on the GI tract and bone, and I talk about those in more detail in the parathyroid video. This is a drawing of a proximal tubule cell found in the proximal tubule of the nephron. In this section of the kidneys, you can find a transporter that reabsorbs sodium and phosphate. This transporter is inhibited by parathyroid hormone. That leads to more phosphate excretion. Shown on this slide is a drawing of a cell in the distal tubule section of the nephron. In these cells, you can find a calcium-sodium antiporter on the basolateral membrane. Parathyroid hormone activates that transporter. This will increase calcium reabsorption and raise the serum calcium level. And then finally, one of the roles of the proximal tubule is to convert vitamin D to its active form. I talk about vitamin D in much more detail in the biochemistry section in the videos on vitamins, but just to focus on the nephron's role in vitamin D metabolism, in the proximal tubule, there's an enzyme called 1-alpha hydroxylase. It converts vitamin D from its 25-OH form to the active 125-OH2 form, and this enzyme is activated by parathyroid hormone. That's another effect of parathyroid hormone on the kidneys. Erythropoietin is also called EPO. This is a hormone released by the kidneys that stimulates red blood cell production in bone marrow to maintain the red blood cell level in the plasma. EPO is made by interstitial cells of the peritubular capillary, and it is released in response to hypoxia. And one of the consequences of the fact that the kidneys make EPO is that there's poor EPO production in renal failure, and that's why patients with chronic kidney disease often develop a normocytic anemia. They are underproducing EPO. I'll finish by mentioning dopamine. Dopamine is synthesized by proximal tubular cells, and at high dosages, as you may know, it's a vasoconstrictor and an inotrope, but at low dosages in the kidneys, it actually can activate dopamine receptors and dilate afferent and efferent arterioles. This will increase the renal plasma flow because you are dilating the afferent and efferent arterioles and allowing more blood to flow through the kidneys. Usually there's relatively little change in the GFR. However, on balance, dopamine can slightly promote sodium and water excretion, and it's considered a natriuretic. It's unclear if there's any physiologic significance of this, and in the past, people would sometimes try to administer low-dose dopamine to patients to improve renal blood flow, but it turns out this didn't help kidney function much at all, and it's generally not done anymore in the modern era. But you should be aware for your board exams that dopamine is synthesized in the proximal tubule, and then at low dosages and low amounts, it can have an effect of dilating the afferent and efferent arterioles. And that concludes our video on renal endocrinology.